Welcome, everybody. Appreciate you joining today's webinar. We're going to give folks another couple of minutes to log on, and then we'll begin. So welcome to those of you who are joining right now. We'll probably start in about 90 seconds or so, maybe a couple minutes. While we're waiting, if you want to maybe pop into the chat and tell us either where you're joining from or where you'd most like to be today. Those might not be the same things. Here in Chapel Hill, it's actually quite gorgeous today. It was a little rainy this morning, but it was 60 degrees over lunch, and so I got in a nice run. Oh, hey, go Chiefs. I'm from Kansas City originally, Catherine, so I'm right there with you. That's awesome. Yeah, Lori, I would much rather be skiing too. And Andrew, I'm over in Chapel Hill, so I see you're in Cary. Let's see, Baltimore, not in my basement next to the furnace. Nice one, Peter. Tampa. I bet that's a great time, I bet, to be down in Tampa right now. I have an opportunity to go to Florida on the East Coast of Florida in about a month, and I'm really looking forward to it. It's a good time of year. Rainy Atlanta. Yeah, sounds about right. For those of you who are joining us, we are giving folks a little bit to join, maybe just about another 30 or 45 seconds or so. And we're just having folks put in the chat where they are coming from today, or else maybe where they'd rather be. If you'd rather be somewhere that you're not. South Louisiana. All right, we have a couple team members down there in the area. All right. The Swiss Alps. Yeah, Mike, that sounds great, especially with Lori's comment about skiing. Awesome. All right. We've got folks coming in from all over. Oakland, Denver. Welcome, Chris. Glad to see you on the webinar. Boston. All right. Well, this is great. Well, it looks like we have quite a number of folks joining, so I'm going to go ahead and kick us off. And I'm really excited today and to welcome you to the webinar, which is looking ahead in 2024 healthcare trends and the rise of personalized healthcare. I'm Drew Schiller. I'm the CEO here at Validic, and I will be your moderator for today's event. So today we're going to cover how personalized care using remotely captured patient health data can alleviate clinician burnout, improve health outcomes, and help patients take ownership of their health and well-being. We're going to talk about the pathway to shift from a traditional episodic care model to more of a continuous personalized care model. And we're going to talk about key trends in 2024 that are disrupting care delivery and accelerating the transition to hybrid and fully virtual care models. Our conversation will include a panel discussion with Dr. Peter Rasmussen and Leah Briggs. Before I pass it over to Leah and Peter to introduce themselves, I'd like to cover just a few housekeeping items. First, this webinar is being recorded, and the recording will be available on demand in about 48 hours after the event, so keep an eye out for an email regarding that with the recording. Second, we will be answering audience questions throughout the webinar, so please submit the questions in the Q&A box below. We'll get to as many of the questions as we can during the webinar, and we'll answer any remaining at the end of the discussion. This is an excellent opportunity for you to get Peter's and Leah's thoughts on what matters most to you. So just to tee us off, before I kick things over to Peter and Leah, I want to start with, I came off of CES, the Consumer Electronics Show, a few weeks ago, which had a massive digital health experience this year. If you haven't checked it out, I highly recommend it. Gail Boudreau, who's the CEO of Elevance Health, gave a keynote. We had a panel session moderated by Dr. G with Glenn Tolman and Mark Cuban, just a lot of really big A-list players and talking about the future of healthcare. And the most enlightening conversation I had was actually with a company that is a defense contractor, and they had worked with DARPA to develop technology to help communicate low bandwidth information across very, very wide expanses. So think about military deployments in a desert where you need to be able to communicate data securely across very, very wide ranges. And I was talking to them about the applications in US healthcare and how this could potentially be used for rural health. And specifically, as we were discussing it, we found some opportunities, and then they showed me a wearable device that they had made with sensors that you put on the wrist, and it tracks the typical things that a wearable sensor tracks, and how that works into their network. And then they said, what's interesting about this wearable device, we can also deploy this on livestock. And I thought, that's interesting. Let me see that. So they showed me how the wearable device actually fits between the shoulder blades of a cow or a sheep or a pig. And they were explaining how it works. And I said, well, how does that work economically? And what I realized as the conversation evolved is that there are better incentives to proactively monitor the health of livestock in the United States than there are to proactively monitor the health of people. And that was really shocking, somewhat depressing. And I feel like that's really what's up for us in this conversation, to start to tease out to see how can we help to shift some of those dynamics, because we have the technology available today. So how can we actually help to deliver better, more proactive care to people in the United States, given the capabilities that we have? So that is all to introduce our panel. And what I'm going to do is kick it off to Peter and Leah and ask them to introduce themselves, tell us a little bit about their role by answering the question, given the context of what I just laid out, what are you thinking about today that you were not thinking of 5 years ago? And Peter, why don't we start with you?
Thanks, Drew. Yeah, Peter Rasmussen. I wear two hats at present. I continue to be a practicing cerebrovascular and endovascular neurosurgeon at Cleveland Clinic, which I do about half my time, and have been there now 25 years. I just got my watch. And the other half of my time I spend as chief medical officer for the Clinic by Cleveland Clinic, which is a joint venture spinoff company that was formed about 4 years ago with Amwell. Our charge there has really been to create global access to Cleveland Clinic experts for patients around the world using digital technologies. Currently, we're working mainly with virtual second opinions, and we're now beginning to work on programs to use technology to manage chronic disease virtually. So I think one of the things you were asking about here, Drew, is what am I thinking about today that haven't been thinking about 5 years ago? And it really kind of ties into your livestock comment here, is that not only is it financially more beneficial probably to manage livestock, but there's probably a whole lot less regulation. And this is certainly something that I think has changed as we've moved out of the COVID era, that the lawyers and the regulators and the compliance people are really paying an awful lot more attention to digital health and technology solutions being applied to health than they were 5 years ago. And I think this is really something that's hampering a lot of high quality care and access to care, unfortunately. But it is the reality of where we're at, which medicine's regulated at the state level. And we're going to have to deal with this for the near future. So a lot of thought going into how do we work within those guidelines, and how do we create digital health services and products that conform to the legal environment we're in right now.
Thanks, Peter. Leah.
Hi, I'm Leah Briggs. I am a registered nurse by background, and I'm the executive director of product for Active Health Management. We're a technology-enabled population health management company. So we provide services to the entire continuum of patient situations and circumstances and life cycle. I've been in population health for about 15 years now, and one of the things that I've really started to embrace is this concept of reimagining the health improvement journey, and really starting to ask ourselves, why can't this journey look more like the journeys you have when you interact with consumer websites and consumer apps and different experiences you have through there? And why do we not have that personalization and those insights that some of the leading consumer brands are able to find on all of us? As healthcare providers, we are an integral part of their treatment plan and their care team, and yet we are not bringing that personalization to the member in the way that we probably could. So really starting to challenge the narrative that it should be different. Maybe it shouldn't. Maybe it should be more closer to that consumer experience.
Yeah, that's awesome. Thank you for that, Leah. And, so again, I'm Drew Schiller. I'm the co-founder and CEO at Politic. And just to quickly say, I think the thing that I'm thinking about today that I was not thinking about 5 years ago as much is a lot more around automation and how do we help to automate some of the tasks that folks are doing, that clinicians specifically would be doing in their day-to-day workflow, that are frankly beneath their licensure. And how do we help to automate some of the basic rote follow-up and maybe education opportunities and surface up what's really critically important for them so they can practice top of license. And I think that there's been a lot of capabilities made available even over just the last year with generative AI and things like that that are opening up new opportunities. So we'll discuss that a little bit further. But for right now, I actually want to stay on the personalization, Leah, that you just brought up. And, if you think about, to extend what you were talking about around consumer brands, you think about how, Netflix is recommending the next show for you to watch, and you log into your Amazon account and it's recommending something for you to purchase based on the last thing that you bought. And, you go to Starbucks and they remember your very specific esoteric coffee order, with 2 pumps of this and know that. And it's really incredible when you think about the level of personalization that we all have. And by the way, McKinsey has stated that 71% of us as consumers expect that level of personalization, and actually 76% of us get frustrated when we don't have personalized interactions. And to your point, we don't have this in healthcare. So I'm curious, let's begin by discussing in healthcare, how do you think, Leah, about personalized care? What does this mean from a healthcare provider perspective? What could it mean from a patient perspective?
I think for me, I want to think about it from the patient's perspective. And like I mentioned, kind of thinking about that consumer experience. But I think first you have to think about the word care and what does that encompass? And I think that understanding that it's never for the patient, for me as the person, it's never been about the acute visit. It's never been about the few times a year that I go into an urgent care or see my PCP. It's about the moments in between. That's when the real health behavior change and the sustained improvements can occur. And so I think to start to talk about personalizing those, you have to know about those moments. You have to know about the patients and the members inside of those events that only happen periodically through the healthcare life cycle. And you have to take all of the clinical information that we have on our patients, but combining that with preferences and the behavioral patterns that I display. We display behavioral patterns every day, every time we log in to check our EHR, or we're hanging out with our doctors. We have behavioral patterns that begin to emerge, and our job as population health management is to create those tools and experiences that help the treating providers inform those treatment plans and really start to match up the right intervention for the patient in that moment. And I think in that way, we're going to get really closer to that personalized consumer-like experience.
Yeah, totally. I mean, at the end of the day, right, people just want to be seen. They want to be known. They want to understand that folks are getting the right care for them at the right time. They don't want to leave their healthcare appointment and go ask Dr. Google for more information, right? Peter, what do you think about this?
Yeah, it's a long-term struggle, and it seems like it's never ending, that's for sure. And clearly, as you mentioned, Drew, patients want to know that you're on their team and that you're advocating for them and that you care. And a lot of the personalization things that you talked about, understanding what is their preferred nickname to call them by, how do they prefer to be communicated with, whether it's email or text, or how do they want to have their visits? Are they in person? Are they telephone? Are they video? These are all things that I think are very important for the patient. They don't want repetitive behaviors. They don't want to fill in their name and past medical history and address ad nauseum and every different form that comes through. So I think those are things that we can work on with patients for sure. As a health system or as a physician, as a provider, what does personalized medicine mean? In my mind, when you're dealing with complex disease and chronic disease, it's really having full access to the data. And that starts with, episodic data when patients come to their healthcare provider, to the hospital, to the ED, these kinds of things, and having that data available everywhere. And that's really a very tricky problem that still hasn't been solved. We're an Epic-based healthcare system. Epic has done a lot to make that data transparent amongst its own ecosystem of affiliated hospitals. But obviously, if someone shows up at a Cerner facility, we've got difficulty accessing that information, even after plugging into every HIE service known to man. We still have trouble getting that information. And that we see that every day in our virtual second opinion program, where we try to collect the data for patients to put them in front of our experts for a second opinion. It's a huge struggle to get that kind of information in. And the other thing about this then is, the personalized data around genetic analysis, which is incredibly important for cancer to know about these things. But certainly, as you and Lee have been touching on, is what's going on with patients in between, and it can be things like behavior that we already talked about, but even moving beyond that to understand the physiologic data that's going on and can be captured for patients in between are incredibly important. As a personal anecdote, a very good friend of mine is recently hospitalized, a very young man with a hypertensive emergency. And, despite having the infrastructure and the technology in place for him to go home, I'm going to bet we're probably not going to give him a connected blood pressure cuff and having that data flowing in to continue to monitor his blood pressure after the fact, right? So these kinds of personalized physiologic connections need to be more formally put in place to allow for that continuous care after the in-person episodic events that we all know about.
Yeah. Well, thanks for sharing that story, and I hope that I hope your friend recovers fully and well. And it reminds me of people. Oftentimes I'll get asked about AI, and I say, look, the AI we really need in healthcare right now is actual integration of the technology that we already have available. that would go really far. And you mentioned folks joining telemedicine visits and things like that, Peter, and thinking about how we're doing this over Zoom, and this is a very normal interaction for us, and something that people expect across all sectors of their life now. So as you start to think about the necessary components to deliver personalized care effectively, just curious, how do we balance providing that personalized one-on-one approach through these new modalities with the increasing demand of care, lack of clinical resources, the overwhelming potential volumes of data that you mentioned? I'm just curious, how do we actually navigate all of that as a healthcare system?
I think, Drew, in a word, it's really technology. There's a tremendous shortage of nurses, tremendous shortage of physicians and advanced practice providers, and other folks in, therapists, et cetera, nutritionists in the entire healthcare arena. And I think the only short-term solution we have for this is implementing better technology. That means better information systems, improvements to things like Epic and electronic health records. But importantly, it's connected devices for patients who have chronic disease. Diabetics, I'm sure, are woefully under monitored in terms of their glucose readings. It's expensive to buy strips. Patients are probably not checking their glucose as often as they should be, and then having that information transmitted to their care team for action in a relatively short period of time and in an actionable way, and not in an overwhelming way for the provider team to acquire this data. So these things are important. Patients with heart failure. We know that there's a shortage of heart failure providers in this country. There's 6 or 7 million Americans living with heart failure at present in this country, and we're not training anywhere near enough heart failure experts to manage this population. So the only way that's going to be solved or helped is using technology to bring the heart failure expert to the patient when it's needed, set the course of treatment for this, and then monitor that treatment plan moving forward using connected devices, digital tools, text-based engagement strategies, telephone visits, video visits, leveraging the appropriate provider at the appropriate point in time moving forward. But so it really all kind of comes down to pulling together the pieces of technology, connect devices, the data flow, the dashboarding, the different ways of delivering care, patients to access care, and then having that synthesized into an actionable form of data that hopefully at some point in time is going to be meaningful use of artificial intelligence.
Yeah, absolutely. Yeah, that's so great. And you mentioned the heart failure example. It's so dead on and such an opportunity. One of our clients, in fact, that has implemented the Validic solution to help with heart failure patients, saw that they were able to go with their existing clinical nursing staff. They were able to move from evaluating 6 patients an hour to evaluating 20 patients an hour without compromising the clinical care. So they could get done effectively in 2 hours what used to take that team a full day. So there is a lot of opportunity to leverage the technology. And Leah, I'd like you to weigh in on this. And but specifically, I'm going to bring in a question from an audience member around capturing data from devices. And the question from Chris is asking, how do you move from transactional data captured, like blood pressure, which is very much point in time, to something that's maybe captured every 15 minutes for a week? So maybe wrapping that into, how do we move from this old way of episodic care and using only data from an appointment versus something that approaches and prioritizes prevention, more condition management, leveraging more real-time data? How do you think about that at Active Health, and how are you approaching this episodic to continuous shift?
Yeah, I think to talk about kind of that continuous monitoring, like grabbing a blood pressure every 15, 30 minutes, I think exactly what you talked about at the CES show. It's really making sure that the innovators in those device industries hear us as clinicians and listen to what we need to be able to manage these members, both in the acute setting, but also in the continuous setting, right? The in the between moments. Here at Active Health, because we're population health management, we've always been just outside of that old way, just outside of that acute episodic care. And so we've always used data, whether it be self-reported, gathered through devices, gathered from the wealth of information we can glean out of the EHRs for the patients. But I'm really happy to see that the healthcare environment with the treating providers are moving more in this space and recognizing that the patterns that we observe Monday through Friday, Monday through Sunday that really tells us far more about the members than that snapshot in time of data that we've gathered in the moment. And so what we've done here at Active Health is we've really invested in supplementing and coming alongside of that shift in the acute episodic delivery of care, and making sure that data we're gathering, we're putting it forth for our patients. We're putting it into that same Epic EHR that Peter mentioned, and getting it out there into the realm where it can be shared on behalf of the patients, because it isn't my data, it's their data. And if it helps Peter when that patient walks in the door at his clinic, then it's good for my patient, and it's going to get them a little bit closer to that health improvement that we're trying to do. And I think about, Peter, you mentioned your personal story. I think about, that member who, 3 times a year is going in and talking to their doctor about that hypertension, and it's just not moving, right? Our population health management, what we're trying to do is trying to find those lifestyle changes and behavior choices that they're making, in those in-between moments, to try and make that change. And really it's taking those blood pressure readings and seeing that pattern that emerged over the last couple weekends, and kind of connecting the dots for those members. Like, your blood pressure is going up over the weekend. And I also see from your food intake logs that is digitally transmitting to me that, you enjoyed yourself at the neighborhood barbecue. Too many hot dogs. We start to be able to connect those lifestyle choices you're making in the moment with the data. And it starts to resonate with the patients a little bit more than just those acute episodic education moments.
I feel, Leo, like you're judging me for eating too much Kansas City barbecue this weekend as I was watching the Chiefs game.
Never.
But yeah, no, you're totally right. And I'm thinking about my own personal story, and Peter, getting back to the story you shared about your friend, my grandmother, my dad's mom, she had COPD, along with a bunch of other conflating factors, such as she was a lifelong smoker and she was obese and relatively sedentary lifestyle in rural Iowa. But she was actually dismissed or discharged from the hospital after being hospitalized with complications of COPD. And unfortunately, she passed away in her assisted living facility in less than 24 hours. And it was because, when they discharged her, they didn't have any monitoring, right? There wasn't a pulse oximeter. There was no way for her for them to see that she was decompensating, even though this is like relatively available technology and relatively inexpensive to put in place. And so, I think about when folks are in particular acute scenarios, why aren't we putting them in a position to where they could be potentially monitored upon discharge more frequently? Because we see really good results with our clients that do this. So I'm curious, how are clinicians today, like what are some use cases you hear about how they're using remotely collected patient health data, whether it's in virtual care models or and maybe in more of acute settings post-discharge? I'm curious if you could share stories that you've heard where there is an actual improved patient experience, provider experience, delivering care with these types of devices.
Is that one to me, Drew?
Yes. Yeah.
Okay. Well, it's it's really only limited to the imagination, right? So, one of the things I did when I was running digital health across Cleveland Clinic was put in place, had my team put in place broad technology solutions that our caregivers could innovate on. And I was always surprised when I would go evangelize what the capabilities were around to the organization, to care teams and providers in across Cleveland Clinic, and how they would think about different ways of doing these things. So obviously, one of the things we did as we implemented Validic as the data gateway for remote home monitoring solutions into our EHR, which was, to Chris's question here, that's one of the absolute necessities that you have to have if you're going to doing these programs, is the data that patients are acquiring at home has to flow into the EHR, and Validic is a great way to do that. And examples of this just around blood pressure, of course, is the management of chronic hypertension or acute hypertension. And then obviously it's very simple to add on things like temperature and blood pulse, respiratory rate, pulse oximetry, and we can easily manage respiratory infections, COVID, influenza, RSV, where that kind of data could leverage earlier discharges from the hospital or avoid hospital admissions from the ED for these things if you had a robust data flow coming in from patients like this. But even beyond that, I was always surprised at how innovative people could be. So I spoke to the Cancer Institute one day, and they asked me to talk to the bone marrow transplant team, and I couldn't figure out what would the bone marrow transplant team do to use remote home monitoring for. And what they told me was, after bone marrow transplant patients would come into the office every day for 3 months to have their temperature taken and their blood pressure monitored. And I didn't understand why. And the reason is that these patients are very prone to infection on the immunosuppressive regimen, and they wanted to catch early infection by monitoring their temperature. And the anti-rejection medications would lead to hypertension, and they needed to know about that as soon as possible to start patients on those medications. And they were able to transition all of these outpatient visits to really video visits, or not even video visits, but remote monitoring, by having the data flow into the EHR and having one nurse monitor this data flow. And that was better patient care. It keeps immunosuppressed patients out of the biologically dirty outpatient clinic. It saves the patients tons of time, and it frees up all of those outpatient clinic slots for other patients to be seen. And it just makes absolute sense to, think about ways to use this technology to innovate on the care model and do things much better for your patients moving forward.
Absolutely, yeah. Not to mention the patient experience is better, right? Like, who wants to actually go into the hospital? No, I think it's a great point. Leah, there's a question here specifically from Greg that I'd love for you to elaborate on. Greg asks if you can be more specific about how active health is helping the episodic based care transition into continuous care, and how that can help the patient and the healthcare system overall.
Yeah. So one of the many services that we provide here at Active Health is a really robust and in-depth care gap delivery and generation. So for many years, we've been taking in all of the information. So not just from the EHR, but from claim information, from consumer information, anything we can get our hands on, and applying evidence-based literature to find those potential gaps in care or obvious gaps, right? It could be medication adherence issues. It can be, duplication of therapy, things that aren't seen very well because of the EHR lack of integration sometimes, and some of the known blind spots we have with the EHRs. And so in that way, we're able to deliver those insights directly to the treating physicians. And coming soon in this year, we'll be able to deliver it and deposit it right into the EHR for their use. So that's one of the biggest ways that we're able to assist providers with that. And it's also being able to gather that information in between the visits, right? So you're working with your members or your patients, and it's like hypertension is a really easy, common one for us to work with. We can gather all of that data and information, synthesize it, right? It's a flat transfer of data isn't any more helpful, and it really probably bogs down the doctors. But really starting to draw those summaries and insights from the patterns, that's where our value comes in and what we can do for physicians.
Yeah, awesome. Yeah, thank you so much for that, Leah. And so another question we have from the audience, I'm going to parlay this into a broader question. I'm going to turn it to both of you. So Bob asks, how are y'all utilizing AI in analyzing data across populations? And, I think probably in healthcare, at least, if not the entire tech world, the biggest story coming out of 2023 was generative AI, which certainly has the opportunity to advance healthcare personalization and workforce productivity. So how do you see generative AI having the biggest impact for personalized patient care? Will it lead to better interventions or giving clinicians more time with patients? Both. I'm curious. And Peter, why don't we start with you, and then we'll turn over to Leah.
Well, I honestly, I think it's a little bit, for it to be revolutionary in medicine, it's a little bit off, a few years off yet. There are some situations where it's being used, so in my own area of acute stroke, we use AI to help analyze CT and CTA images to help us identify candidates for stroke intervention. Here's an example of using it for that. Our orthopedic surgery department has begun using AI tools to predict the risk of nursing home placement after total joint surgery, risk of wound infection, risk of prolonged hospitalization, et cetera. And this seems to be a very effective tool to help in the personalized decision-making for patients who are deciding to move forward with surgery around total joint therapy. And you can really imagine all sorts of ramifications that come out of that. If you can predict the risk of needing nursing home placement after joint surgery, you can probably predict the risk of heart failure exacerbation in the next 6 months for somebody who has heart failure. So I think these are really great applications of AI in the near future that will help manage populations of patients and focus scarce resources. One area where I don't think it's really going to be particularly all that helpful, in my personal opinion, and I have dinner with Toby Cosgrove every few months, and he keeps telling me that isn't going to be great when AI is going to write your office note for you. And I said, well, yeah, that might be nice, Toby, because you've already given us the tool to do voice recognition. But if I'm that much more efficient with my office note, you're just going to make me see an extra patient every hour. So it may or may not actually help me to be truthful about it. It all sounds nice, but I'm pretty sure the administrators aren't going to let me sit down for 10 extra minutes and have a cup of coffee each hour because it saved me some time. So that may or may not be a beneficial aspect of AI.
That's a really interesting point. Yeah, good for the top line, not necessarily good for good for everybody else. Leah, what do you think about generative AI and how it could help?
Oh, I'm going to take another view of that last comment, Peter, that you made. It might actually mean that you're able to see one more patient, but maybe that's what we need. Maybe that will help to alleviate in the short term some of that provider burden that you mentioned. I had a recent family member who needed a mental health provider. It took her 7 months to get a mental health provider, and she has commercial insurance. On paper, there's no reason not to. There just isn't people to do it. And until we can catch up and start training enough physicians and especially the specialties, Peter, that you mentioned, we have to figure out ways to get people the care that they need, whether it's in non-traditional settings, whether it's eliminating some of the administrative burden that we've put onto not just the physicians, but the entire system. I think there's plenty of applicability there. I'm hesitant in the space where we start to talk about putting AI in front of a patient, as I think most clinicians are. That makes us very nervous with the level of hallucinations that it still has. And I think it will be some time before any of us feel comfortable with that. But I think as we look at everything from the note generation to those digital devices we were talking about, right? AI can really do some amazing processing of huge volumes of data that it would take humans so much longer. If it can help us get speed to market on some of these devices, I think it can really, escalate the adoption of the devices in this continuous care process.
Yeah, thanks for that, Leah. I'm gonna split the difference between you two on the impact it can have on clinical care for clinicians, and I'm gonna borrow actually something that I heard from Dr. Ami Bhatt, who's the Chief Innovation Officer at the American College of Cardiology. And I actually had the opportunity to host a panel session at CES that Ami was participating in, and she brought up that one of the things that AI could potentially have the biggest impact on today is helping to rank which patients need to be seen now versus which patients might need to be seen, might be okay waiting. So if you have 20 patients where you need to review their lab work or their casework or their scans or whatever the case may be, current course and speed, you're doing that in order, right? And who's to say that the patient that is 20th on that list that you might get to in 3 to 4 hours actually needs to be seen ideally in the next 30 to 60 minutes, but you have no way of knowing that, right? And so if there was a way for AI to surface up and say, hey, this is looking like somebody that you would probably want to review their labs or their results first in a prioritized order, that can at least help get your eyes on that person or on those results while they're fresh, while your mind is fresh, I should say, and then also surface that up to the appropriate clinician if that's not yourself, so that they can take an intervention sooner. So I thought that was a really interesting use case, and something that doesn't impact clinical decisions, so to speak, but it definitely could impact meaningful clinical care and patient outcomes in a very timely manner. So I think, yeah, I really appreciate that. Yeah, Leah, you got something to add?
Yeah, I think it's really important that we acknowledge that the inputs into the AI is just as important, right? If we're not taking into account certain cultural and behavioral inputs into that, we could actually do damage and exacerbate the health disparities that we're already trying so hard to combat all around in the healthcare environment. So I think it's really critical that you, when you're implementing these things and you're exploring them, that you're thinking about the totality of information that starts to describe that member and that patient's experience, and not limiting it just to the clinical conditions, because that's only part of the story. We have to make sure that we're taking in all of their social determinants of health, both known and predicted at risk for conditions. All of those need to be inputs and have the models trained on it to make sure that we aren't doing more harm.
Yeah, absolutely. Yeah, I really appreciate that. So we got a question from Mark, who says, this is good stuff. He has a quote, one trick pony question. for the panel, which is how do you get people to actively engage? First for the episodic events, and then to transition into ongoing engagement to prevent readmissions and relapses, ongoing compliance. So anyone want to take on the question of how do we actually get folks to engage in these type of proactive monitoring programs?
I can tell you from Active Health's perspective, one of the things that we are really big on is marrying up that behavioral input, everything we know about you as a person and how to best to communicate with you. There is a ton of strategy out there and literature and evidence-based literature on how to motivate people to make behavior changes. Getting somebody to do what they either don't know they need to do or they don't want to do is at the root of all of our jobs on this call. And so deploying those type of behavioral communication practices has really made a difference in our engagement rate. And that doesn't just start from the actual clinician to patient conversation. It starts long before. It starts in the marketing of the program, the explanation of the program, and making sure that you are speaking to people in a personalized manner. Drew might respond to a communication that is very checklist driven, and so we make sure that we have content that speaks to him, because we've seen in his past behavior he's more likely to pick up that phone and call us or log in and chat with us if we send him this type of communication. And being willing to do that A/B testing, the test and learn on the types of strategies to get somebody to do what you want them to do is going to be critical. And having the space to learn is going to be good for that.
You know, the other side of that is on the provider side, right? So Leah talked very eloquently about how to engage patients and members on this, but on the provider side, how do you get them engaged in this? And it's very difficult. So for instance, I deal with stroke patients, and monitoring blood pressure is very critical. And I have about a half a dozen patients of my own that I try to monitor remotely for their blood pressure, and that's just work I'm taking on extra. Right. So all of my other clinical responsibilities, and then I'm looking at these patients' blood pressures as well. And I don't think it's possible to ask the clinical workforce that's out there right now to engage in remote patient monitoring and management strategies and without building some capacity into their schedule to take that on, or to create separate teams to do that monitoring and management for you. Right. So, and this is no new idea. I heard this 15 years ago from Richard Milani down in Oxnard Clinic, where as a primary caregiver or a physician, you could just write an order for home blood pressure monitoring, and their team would swoop in and put those patients on the home blood pressure monitoring and management program and take over from there. And because that's what these people did, they were totally dedicated to it. They had very, very high rates of clinical success and patient compliance with that program. But to sort of ask a busy clinical service to do that in addition to what they're doing just isn't going to work. I'll give you a great example of this at the Cleveland Clinic, the world's greatest heart hospital by many measures. There's a very robust technology for managing patients continuously at home for heart failure called CardioMEMS, standard of care for very direct, very defined reasons and populations. I was just talking to one of our heart failure cardiologists this morning, and they have less than 100 patients being monitored using CardioMEMS. Why? Because there's no system in place. We put no system in place to use CardioMEMS to monitor that data moving forward. So, this is a major barrier that if there are healthcare administrators on this call, plead to them, think about this, help create programs to do this. This is the right thing for patients. These are devices that clearly lead to reduced ER visits and readmissions to your hospital. And that's a major barrier. And the other major barrier that exists here, and I know Ron was adding this into the chat a second ago, is there's not clear defined reimbursement pathways for this. And as many of you may know, I advise a number of individuals on billing and coding for RPM, and it's incredibly complicated and obscure how to do this. The rules are very, very difficult. And for the payers who may be in attendance and the regulators in the audience on this, please work to streamline these rules and the way that these codes can be applied so that the reimbursement pathways that do exist for these solutions can be better implemented.
Yeah, thanks for that, Peter. And plus one to that last statement, and thank you for your work on that. I know that you do a lot of advocacy, and helping with organizations that are looking to bill for these type of services. I will say, to plus one and add to your point around clinical capacity, we find that there's two kinds of clients of ours who do perform really, really well with these types of programs. One is organizations that have made a complete shift in the way that they deliver care to where this is part of the clinical capacity for the day-to-day team members, right? And the benefit of that is that the care team that's prescribing these programs for patients is the same care team that's also reaching out and discussing with folks. And it creates really strong patient engagement. People feel like they're part of a team. It's not just, the patient is trying to do something for themselves and then they go to the doctor every once in a while and hear what they did wrong. It's like they have a team approach. And the other type of client that we have that performs really well in these programs are exactly what you suggest too, where they actually have a separate center, like a separate centralized care management center that helps onboard patients in these programs, that answers questions, that reaches out to patients proactively. They become the care team. They're not the original sort of prescribing team, but they become the care team. And I feel like one of those two scenarios needs to be true in order for organizations to scale beyond just like a few dozen active people. We have really, really strong results around that when those things are in place. And we unfortunately have, poor use cases, examples for clients that try to shoehorn this into the traditional fee-for-service model without expanding the capacity for clinicians. So I think that's directly to your point. So I'm curious, like we're talking about 2024 trends. We're kind of coming down to the last 10 minutes or so. So I'm curious, like, if you guys could call your shots. So what do you predict? Like last year was all about ChatGPT and generative AI, and that was the big thing. What do you predict will be the emerging trend in 2024 that will change care delivery, accelerate the transition, how we think about these virtual or personalized care models? Peter, why don't we start with you?
Drew, honestly, I don't know. I can tell you what my personal goal is for 2024, and that is to drive deeper adoption of technology and digital tools and virtual care for patients to actually begin to manage patients. We hear so much about remote monitoring. Okay, monitoring is great, but you got to take it to the next level, and you actually have to manage patients and help them with their disease process. So, and it's not just one solution, right? It's not just a connected blood pressure cuff. It's not just a video visit. It's pulling all of these different technologies together into a meaningful, harmonious solution that's actually going to change care delivery. And then it's got to be sustainable, which means you have to get paid for doing that kind of work. So not only do you have to think about what's clinically relevant and how to deliver care, but it's like, what is it going to be meaningful to the payers, and how are you going to get reimbursed to do this kind of work that's going to benefit the patient and the health system and the payers. So work to find a creative solution and understand what the pain points are for the patients and the payers alike, so that you can create a sustainable model of care delivery in the future.
Yeah, absolutely. I like that. Leah, what do you think?
I don't think this is as much emerging, but something that I'm eagerly waiting to see the impact of this shift that I feel is coming, and the implementation is going to be strong in this calendar year, is the shift of care from kind of traditional settings to more alternate settings by non-traditional entities. I think that has the power to really put a lot of pressure on the traditional healthcare providers to respond and react to that. We're going to start seeing more and more primary care in the home, and you really don't get more personalized than that. Having your nurse practitioner sitting across your kitchen table, I mean, that's personal right there. And so I think that is going to cause some disruptions in how we've seen traditional delivery of care that I think will help to accelerate some of the moves that I think patients are demanding.
Yeah, that's really interesting. When I think about this question, it's hard for me to not be curious about what the impact over the next year is going to be around GLP-1s. Because for the last long, like, decade or so, we've had a number of virtual clinics, more direct to consumer, that have popped up. And frankly, a lot of them are for programs around Viagra. Like, that's 80% of their business, right? And now there's a new miracle drug, so to speak, that is, I think, maybe reinvigorating even more direct-to-consumer opportunities for healthcare and hopefully proactive health. But we've seen, Weight Watchers make a big shift to prescribing this. We've seen the same from Noom. We've seen a lot of more consumer-focused companies are now kind of shifting to prescribing this, and there's going to be a big fallout from it. I'm curious what that's going to be. And I think that it's going to be really interesting to see, especially given that we don't yet know all of the implications of the drugs long term, how it affects people when they're on this for a long period of time, if we can actually drive sustainable behavior change, because I don't believe there's anything that's a true miracle drug. But that's the thing that I think about a lot in terms of what's going to be sort of changing the landscape for healthcare in 24. I don't know if there's any additional comments on that, but
Drew, as Thomas Sowell said, there are no solutions, there's only trade-offs. And that's kind of what you're alluding to here, and around GLP-1s. But the thing that these kinds of programs and these online Viagra programs have fostered is the potential for limitation of actual medical care delivery. Not that this isn't medical care, but you know what I'm saying, is more traditional care done digitally. And there's conversation going on right now that there may be some regulation put in place about the geographic distance between a patient and a provider and their ability to prescribe regardless of licensure. Now, this just doesn't make much sense to me. But clearly that kind of regulation is probably some kind of attempt to limit exactly the behavior that you're talking about. Right? There's no reason that a competent cardiologist or primary care physician can't be managing someone's hypertension, at 3,000 miles as opposed to 30 miles. Right? There's no reason that can't be done. But if we have too much of this kind of behavior going on, that we get regulation that's going to limit the application of technology and digital tools, then we've really taken a step backwards.
Yeah, it's really interesting. You pre-answered Lydia's question a little bit, which she was asking if you see changes coming relative to being able to treat patients across state lines, and specifically, she mentions that with her healthcare organization, there are patients who move to the south in the winter that they still are treating up in the north, but they can't, because of the where the patient is located, they can't actually do what's best for the patients. So are you seeing that the GLP-1s could actually threaten positive progress on that front?
Well, I think we've certainly had, even without the GLP-1s being involved, we've had changes in the posture of the health system attorneys nationally. And there's been some very good articles written in the New England Journal about this earlier in the year, or about a year ago, where hospital attorneys have limited the behavior of virtual visits for patients in states that where the physicians do not have licenses, and that's regardless of whether they're established patients or not. So many health systems will still allow for video visits for patients who are established within a short time frame of an in-person visit. But even that's beginning to change in many healthcare systems, where you just simply can't do that behavior at all unless you're licensed. And that certainly is something that's happened in Cleveland Clinic. I saw a patient a month ago who lived on the West Virginia side of the Ohio River, and he was scheduled to have a video visit with me. And, I'm so paranoid now about this that I had my nurse call him and say, hey, you're going to have to drive across the bridge and sit in the McDonald's parking lot in Ohio when we have the video visit. because I'm not sure where it's going to happen, what's going to happen if somebody finds out about this. So and that makes no sense, right? That literally makes no sense. But that's kind of where we're at with it right now in many healthcare systems, and I hope there can be some rational thinking applied at the policy level to this kind of behavior.
Yeah, absolutely. It's 20th century regulation and 21st century technologies, right? Yeah, that's a really interesting and I think very poignant example. And so I'm gonna roll into our last question here. I'm gonna combine a question that I had as well as one from Andy in the audience, which Andy's saying, any parting comments on the greatest successes you've experienced by applying best practices and change management as part of workflow transformation? And I'll add to that, look, as organizations are looking at shifting away from more of the episodic care delivery model to more of a continuous personalized care delivery model, like where do they start? What's been going well? How do folks get started in this whole thing? And Leah, I'll turn it to you first.
Yeah, so I go back to my nursing process, right? The first thing we have to do is assess. When you want to get into those in between moments with your patients and your members, you've got to watch, you've got to listen, you've got to talk and find out what's important to them. Don't assume that you know. And once you start to observe what's happening in between those visits, then you can start to figure out where the solution lies. And in order to really facilitate change, you've got to have a what's in it for me moment. And as much as healthcare providers, we are in it for our patients, it cannot, like Peter said, add complexity, burden, time to an already overworked workforce. And so you've got to listen to them. You've got to assess the people that you're going to put this new task on to make sure that it's simple for them, it's simple for your patients. And I think, as you're starting to look to expand in this space, those early failures you mentioned, Drew, look for a partner that has done this before. Look for somebody who can help deliver the insights with the devices and with the lifestyle and wellness coaching to change those behaviors. I think that's a really safe entry into the market to help get your feet wet and see if it's really going to work for your patients, because every practice is different.
Absolutely.
From a health system provider perspective, I mean, change and change management is best accomplished at the highest level of the leadership. So when there's a very clear message coming from the leadership of your organization that this is what we're going to be doing, this is the direction we're going in, that there are OKRs and KPIs set around this kind of behavior, then you're going to be able to, then you begin to see some actual change within your organization. And when the focus is taken off of those kinds of things and emphasis is placed someplace else within, you're going to see the behavior change in a different direction. We had very strong clinical leadership support for very broad adoption of virtual health a number of years ago. And in the post-COVID environment, the focus has been taken off of that. And we seem to be settling back to a percentage of video visits in the single digits. And that's where the organization seems to be happy or want to be for some reasons that are probably opaque to me. But if you want to make that kind of change, it has to start at the top, and then it has to be cascaded down from there into the individual level. But all that being said, it doesn't mean you can't get started at the local level on your care team and begin to use these kind of tools to move things forward and create some buzz and excitement about it, and hopefully get broader adoption across your organization.
Yeah, absolutely. Well, listen, I will plus one both of those comments, and I'll just add that, having the technology available that patients want to use and having the technology available in the clinical workflow so it's seamless for clinicians to use, I think is table stakes and something that is very doable today. And frankly, the biggest challenge I see at the end of the day is the will of the organization to really get to Peter's point. And if that is there, the technology exists to put it in practice. It really is just, are we going to be for providing proactive healthcare to patients in 2024 or not, is really what it boils down to. So look, hopefully we can all keep moving the ball forward and getting there. I really appreciate Leah and Peter on this webinar, and thank you, audience, for your participation and for the great questions. If we didn't get to you, please send us an email at hello@validic.com, and we'd be happy to answer your questions offline. And again, this recording will be available over the next 48 hours. So thank you so much again. Have a great rest of the year, and I look forward to speaking with you all soon.